Hello, everyone. Thank you for joining today's QTECH meeting. We'll be starting in just a couple minutes. Hello. Thank you for joining today's QTECH committee meeting. We'll be starting in just a couple minutes. Hello. Good afternoon. Thank you for joining today's QTECH committee meeting. We'll be starting in just a couple minutes.
All right. Good afternoon, everyone. We still have a few folks joining, but we're going to go ahead and kick it off. Good afternoon, and thank you for taking the time to join us once again for our monthly QTECH meeting. We certainly can't start off today without expressing our continued gratitude and support for the efforts you and your teams are taking each and every day, especially during these times. You truly are our healthcare heroes, and I think it's important we always start off on a positive note. With that, we do have an exciting agenda for you today. We will be going in. Next slide, please. And next slide, wonderful. We will be diving into some insights and tactics around patient engagement and provider burden. We are excited to welcome two guests who will be speaking about their experiences today. And following that, we will be diving in, bringing you up to speed on some more resources that are available to you and your teams. And then we'll be wrapping up for ideas for our next month's meeting. And with that, I'd like to welcome Jillian Mancini. As you all know, over the course of the last several months, you've heard our team highlight several resources provided through the HITEQ Center. The Bureau, just quick, I won't steal your thunder, Jillian, but this is a tremendous training and technical assistance resource to support our health centers with continuous quality improvement. And we're very excited to have her join us today to help us dive further into patient engagement. So with that, Jillian, I'll hand it over to you. Thank you for joining us today.
Great, thank you so much. We can go on to the next slide. I should say I'm Jillian Mancini. I won't belabor any points introducing myself, but I will say a little bit about the HITEQ Center. So I'm here from the HITEQ Center, which is a HRSA-funded TA and training center. So we provide free TA and training to health centers in all areas related to health information technology. You can visit hitechcenter.org or email hitechinfo@jsi.com to learn more or to ask for any assistance of anything that you need, or obviously you can reach out to the folks at Health Choice Network. We have a great relationship. And our services are going to change a little bit because we just got refunded for another 3 years. So we'll be years 6 through 8 coming up, which we're very excited, and lots of opportunity to enhance our offerings, which I think there's lots of opportunity to do as we've learned so much during the COVID-19 pandemic. As you may have seen in the introduction slide and related to what we're going to discuss today, we, HITEQ, are working on an electronic patient engagement inventory. Obviously, using technology to engage patients has only increased during COVID-19 and really even before that. And there are many tools out there. If you're using any texting, messaging, campaign type tools to engage your patients, we would love for you to complete that inventory. It's a SurveyMonkey. It's relatively straightforward. If you don't have the link, Health Choice Network can get it to you. It's available in this slide deck that was sent out. Oh, and it's in the chat, which is great. And we are always incredibly grateful whenever health centers are willing to share their experiences, because we're able to then share that nationally, which is really meaningful. So thanks in advance for considering filling out that electronic patient engagement inventory if you're using any particular tools. We really, really appreciate that. We can go to the next slide. So our objectives today are that by the end of my particular part of this, you will be able to describe why patient engagement is important to the success of telehealth in a health center. So we're specifically thinking about this need for patient engagement around the launch of telehealth, particularly if that's new for your health center. And then the second thing is be able to specify at least one benefit and one drawback for each patient engagement approach outlined. And then 3, discuss at least one mitigation strategy to be sure telehealth is available and or accessible to all patients. Next slide. So we really see the situation in this sort of 3-pronged way. And obviously this is really evolving as we're several months into the pandemic at this point, and Maybe things are open in some locations, although with some of the spikes that we've seen recently, we may be reconsidering some of those things. I'm in North Carolina, and we're in a little bit of a limbo in terms of seeing some spikes. So some things that were going to be allowed to go forward, some elective procedures and things like that, are no longer. But what we're seeing here is the need is that patients need to adopt or be willing to adopt telehealth. And health centers need to have systems in place to support that adoption. You know, if we want to keep people at home whenever possible and provide services via telehealth, we need them to be able to do that, right? And then the opportunity is to communicate to patients the benefit of telehealth and prepare them for use of telehealth. You know, this may be all new, so really prepare them for that. And the solution that we see is to select a primary approach to patient engagement and then create and roll out a comprehensive communication plan using that tool. Next slide. So we're going to start by talking about what to communicate. What do patients need to know in order to successfully use telehealth? Next slide. So telehealth is a huge change in how we do things. All of the behavior that goes into giving or getting care has changed in some way in the last couple months. We may be able to compel our providers, staff, and sites to adopt telehealth for a number of reasons, you know, because it's what we need for sustainability, because it's maybe the only way we can currently see our patients or some of our patients. But patients can be much more challenging since they have many, many contributing factors, right? They have competing demands, lack of clarity around the availability of services. You know, they just may have no idea how services are currently being provided. They may have concerns about accuracy, value, or security of telehealth. Patients may also have some external limiting factors like lack of broadband, lack of cell service, data, et cetera. Now, you may be familiar with what's on the slide here. This is the FOG behavior model of change. And the thesis here is that there are three components to behavior change. And those are motivation, ability, and trigger. And that trigger is something that prompts the action. Ability and motivation need to be in such a place that when a trigger occurs, the person can take action. So let's go to the next slide. For our purposes, we may think about motivation as the explanation of the benefits to the patient, and then we may think about ability is preparing the patient to use telehealth and telehealth technology. Then when the trigger happens, which is that the patient needs to be seen, they sort of know what to do, right? When thinking about this behavior change model, we want to use patient engagement and marketing to sufficiently increase motivation and ability so that when the trigger happens, the patient can and will take action. Next slide. So as I said, the sort of first thing is motivation. And in this case, we think of this as the benefits to the patient. And so how do we explain those benefits to the patient? How do we communicate it to them? Some of the benefits of telehealth are a decreased risk of COVID-19 by not having to go into the office or being able to stay at home. Ease of access, no transportation needed. You know, they can stay home right now. Health centers don't have to be originating sites. They can, so the patient can be at home and be seen. If a patient is still working and has technology, they may not need to take time off. They can do the visit on a break at work. They can do it from their car if they choose to do so. Also, no childcare is needed. Video conferencing allows for many of the same services as in-person visits. So any concerns that they may have about, well, I can't get the same thing, using video conferencing can really address much of that. And then allowing continuity of the provider. What other benefits are there to the patient with telehealth? I'd love it if folks would chat in some of the things that you've seen. And you can just use the chat on your screen. I've got it up on my screen. Some things that I've heard from others are a decrease in no-show rates, specifically for behavioral health services, that patients are much more likely to show up for their appointments via telehealth than in clinic. I've also heard some really good results, some real benefits for patients with anxiety. Okay, we'll keep going forward. Next slide. And so then ability, as mentioned, is preparing patients to use technology. And this is bolstering their ability by preparing patients to use technology. It really can be multifaceted and super complicated sometimes. There are lots of excellent resources online to help prepare patients, and I'll show you one of those in just a moment. But really, we need to make sure that patients know how to download any apps required, if we're using Zoom, for example. Make sure that they've sort of made a plan for having access to internet or cell phone data if we're doing a video conferencing televisit, ensuring the settings are configured, identifying a private space for the visit, making sure that the patient knows, this is very much like an in-office visit where it needs to be a private space. You need to make sure nobody else is around, finding that well-lit area, and then knowing to turn on their video and stay in one place for their visit. So really preparing patients to use that technology. Next slide. A great example of a resource that's available to assist patients with using the technology is this page here from UCSF. And the link is on the slide itself, and I believe these slides have been sent out to you. And what this page includes is video instructions for downloading Zoom for both Android and iPhone in a whole host of languages: Cantonese, Mandarin, Russian, Spanish, and I believe there are three more languages on this page. And I've heard from a number of other health centers that the providers find themselves acting as sort of part-time patient IT support for part of the visit as well, and part of the challenge being downloading the needed app on the right platform, et cetera. And really, sending this out in advance can be really helpful. Oh, so somebody commented, we found that sometimes patients want no video for integrated behavioral health telemedicine. Yeah, I've heard really people going both ways on the video thing for behavioral health in particular, but even more broadly for telehealth. Sometimes I hear that providers don't want to use the video, and sometimes I hear the patients don't. And so, having some talking points about why it's important to use the video and how it really helps to see body language and things like that can be really important. So again, all of those things that sort of need to be communicated to the patient in order for them to be sort of ready to use telehealth are really important. Next slide. And so then the trigger, this is, as I said, this is the thing that spurs action. And so the trigger in this case is that the patient needs care. Maybe they have a concern about being sick. Maybe they need an ongoing behavioral health service. Maybe they have ongoing chronic care management needs. Maybe they need a prescription refill. We've heard a lot about MAT during this time and how that's being addressed via telehealth. So any number of reasons that the patient could need to be seen, again, this is the thing that's going to prompt action. So we want to have improved the motivation and ability enough so that when this trigger happens, the patient's ready to go and knows sort of the availability of telehealth and how to act on that. Next slide. So just to level set before we discuss engaging and communicating to patients, we obviously need internal processes in place to support this. We need to have a telehealth platform selected and functional. I'm fairly certain you all or most of you have that at this point. You need consent processes in place, likely a process to do that remotely, whether it's that you're doing it verbally and documenting it or doing it through DocuSign or something like that, or doing it through your EHR. Through the portal, for example. You need providers who are ready, willing, and able to provide telehealth visit, the availability in the schedule, telehealth visits set up in your system, things like that. You need a workflow for determining which patients can and should have telehealth visits and the ability to do so in your scheduling system. And then you need to have clear documentation expectations, clarity around what's needed for reimbursement, what's needed for consent, as I mentioned, things like that. Next slide. So this is just a sample workflow for a remote visit, and I know it's too small to see, but it is a helpful workflow in general. But really, I just want to stress that we're sort of talking about this first part, the sort of before the time of the visit? How do we get patients ready in advance of the visit? Next slide. And so then, again, talking about that opportunity, identifying the benefits of telehealth to patients, it's minimizing the risk of exposure, it's ease of access, it's no time off, it's not needing childcare, it's continuity with your provider, whether it be behavioral health, primary care, et cetera. And then next slide. And so again, the thesis here being that selecting a primary approach to patient engagement is really going to sort of smooth out your process. So are you going to get all your patients to download your portal? You know, this varies pretty widely by EHRs. Is the portal any good for your EHR? If it is, then it can be a really great opportunity, and we'll talk about that. Are you going to use email or text to let your patients know the plan and what's available and how they can schedule a visit? Are you going to proactively call all your patients? I spoke to a health center last week who's, I think 18,000 calls into this. They are calling all their patients and letting them know what services are available. Or will the whole thing be ad hoc, see who calls and sort of keep it rolling as it goes? Now, we're 3 months into this at this point, so presumably everybody has some type of plan, but there may be opportunities to improve that plan by using sort of a primary electronic patient engagement approach. So next slide. So we just talked about what we're going to communicate and what the purpose of that communication is, which is, again, to improve that motivation and ability so that when the patient has a trigger, they know that telehealth is an option and they're ready to use it. And the next thing to figure out is how we'll get this information to patients. So we've now figured out what we're going to tell them, what they need to know. And so now we need to figure out how we're going to get it to them. So I'd love it if folks would chat in and let me know how you're currently sharing this information. How are you currently letting patients know about your services? Whether it's telehealth, or maybe you are doing some in-office, or maybe you're dedicating one site to telehealth, one site to potential COVID-19 cases and one to not. How are you communicating that with your patients? We can go to the next slide while we wait for that. And so how to select that primary patient engagement approach. We propose that you need to identify a primary approach to patient engagement that you'll use to communicate with patients to support telehealth. There are a number of considerations that go into this, and these include your patient demographics and preferences, EHR and health IT functionality, and internal capacity and processes. When we think about our patient demographics and preferences, it's really, what portion of our patients have access to smartphones with data and or broadband? Maybe this is a question we've asked before and maybe it's not. So somebody chatted in that Facebook and the health center website is how they're sharing that information. That's great. That sort of pushes the information out, but maybe doesn't proactively reach all of our patients. Social media is definitely a key way, but it's hard to know whether all of our patients see our social media. It's hard to track who that's getting to. And then somebody else chatted in that when the patient calls for appointments, we're letting them know. Somebody said they're using care message. That's great. We would love to have you do our electronic patient engagement inventory. And then phone calls prior to the televisit, the day before, and our website. So understanding sort of who telehealth is going to work for and what the approach should be. So somebody said our phone system greeting starts by promoting telehealth before giving options. That's a great idea. And again, so for people who are seeking information, that's a great way to communicate it. Going back to the slide, thank you all for that input. That's great. And I think there's lots of good options there to communicate with patients when they're coming to you. And I think these are all really good. And we propose that there also needs to be a way to reach those patients who maybe are not coming to you, but need to know that you can help them if they need it. So again, patient demographics and preferences, it's about whether they have access to smartphones, data, and or broadband. You might not have this information currently, but if you're calling patients, this might be something that's asked. One HCCN that I was talking to recently is doing a digital literacy screening as part of their outbound call so that they can sort of have that as a piece of information on their patients. Also, studies show that portal usage is lower among African American and older patients, even when controlling for access to technology. So depending on your patient population, it may be a heavier lift to get some folks to use it. And obviously primary language. Portals are not available in all languages necessarily. Texting can be limited. So addressing those linguistic needs is really important as well. And then thinking about your EHR functionality and existing processes. What functionality currently exists within your EHR portal? Have you been using your portal prior to COVID-19? Few users love their portals, but if you've had any successes, this may be the opportunity to build on them. Are there processes and procedures in place for the portal or for other communications? What has worked in the past? And then do you have the staff capacity to manage communications or make calls? We'll talk about how we might divvy out that time in the next slide. Let's go to the next slide. So you may decide to segment this process using high touch approaches for patients who are at higher risk and lower touch and perhaps higher tech approaches for patients who are at lower risk. So for example, if you have staff to make outgoing calls to let patients know about your services, you might use that staff time, assuming it's limited, to reach out to your highest risk patients, your patients who have the most risk factors, either for COVID-19 or just, comorbidities in general. Those patients may need high-touch care coordination, might need frequent one-on-one interaction, and might be less able to adopt telehealth. They may just not have that capacity, either technologically or otherwise. And so that might be where you dedicate your sort of staff time, direct outreach, et cetera. Then you have your medium-risk patients. And so they might need outreach for coordinated care for stable conditions, might be better able to adopt telehealth with some assistance, and we can talk about what that assistance might be. And then you have your lower risk patients, and this is going to be focused more on coordination and prevention, more likely to have minor health issues, and virtual and mobile access are appropriate, including self-service. So these are the patients who can really thrive with electronic patient engagement approaches to just keep them informed so they can send messages to the provider if that's something you're offering. And that can take some of the pressure off the call center, off the staff who's doing your outreach calls, for example. So thinking about segmenting your patient engagement might be a valuable consideration as well. Next slide. And so I should have said on that segmenting the patient engagement, maybe you're using population health management tools that can help you do that segmentation. Maybe you're doing risk stratification that can help you do that segmentation. Maybe you're using your care management list, how you're identifying patients for care management. Maybe you've got a set of conditions you're using for that, and that's how you're identifying it. So any process you're currently using to do sort of risk stratification or population health management can work for this as well. It's sort of essentially the same type of division. So two examples of primary approaches. One is texting and one is patient portal. And as mentioned, these are certainly not our only options. These are just two that we're going to profile today. Next slide. So the first primary approach that we're going to talk about is the patient portal. So the benefits of the patient portal are that it can centralize your patient communication. It can reduce call volume to the clinic. It allows many types of communication. Messages can be pushed out to the portal. Messages can be received from the patient. Sometimes images can be shared. Test results can be shared, etc. Depending on the telehealth platform, it may be easily integrated into the portal. Some EHRs, the telehealth is integrated directly into the portal. It's all very seamless. And even if you're using a separate platform, you can usually send a link through the portal. And it can empower patients who are able to access it. As I mentioned with some of those sort of lower risk group of patients who are maybe a bit more self-sufficient or are looking for more self-service tools, it can really empower those patients depending on what you've enabled in the portal. And then drawbacks, many clinics have low portal adoption. That may not be news to anybody. It may be hard to get patients to download the patient portal. Some EHRs don't have high quality portals. The functionality on them varies pretty widely. And you need to have a process in place to manage the portal, like portal messages, scheduling through the portal, et cetera. And so if that's new, that might be something that needs to be addressed. Next slide. So rolling out a portal-first approach. So you start by preparing your portal and staff for the rollout. And so this will include enabling your needed functionality, such as the ability to schedule video visits. And this includes both actually enabling this functionality through the portal, ensuring that providers have telehealth visits available in their schedule, and configuring telehealth visits in your system, including linking any pre-visit questionnaires or forms that will be pushed to the portal for completion prior to the visit. This may also be planning for and enabling test results to be pushed to the portal, which may be particularly compelling for patients who are getting COVID-19 tests and awaiting results. So if that's what we're going to do, if that's going to be our hook, then having that process in place so that when patients sign up and maybe they are getting tested, that test result comes right to the portal for them. We want to create comprehensive instructions for downloading and accessing the portal and accessing telehealth through it. So we want to use clear, simple language and images and/or screenshots whenever possible. Consider translating into multiple languages to meet patients' needs. Some EHRs have videos in multiple languages that you could send to patients, and I referenced that page earlier, that website earlier that has instructions for the 2 different smartphone platforms in 10 languages. Those videos can be sent to patients. And it's really important to learn from experience in this step. What have patients struggled with when trying to access the portal? And so as I mentioned earlier, one of the things that I've heard patients have struggled with is knowing how to download the apps. Sometimes it's knowing how to access the App Store. So I've even seen some clinics offering guidance on their website as to how to reset your Google Play Store password or reset your Apple password, your iPhone password. So learning from experience there, capturing those lessons learned as to what those challenges have been in accessing the portal and/or accessing telehealth from the portal, and addressing those as you sort of iterate on this process. And then you want to post those instructions wherever your patients are, as several people mentioned already, on your website, on social media. Include it in your link, in your email signatures. Tell patients about it over the phone. As somebody mentioned, they're using their phone system to promote telehealth. You may also be able to promote the portal as a way to access it. And then you want to monitor your portal activity if you're rolling out a portal-first approach. And so that's going to be establishing your baseline, how many patients are currently using the portal, and then monitoring for portal sign-up and use. So this is the general framework we recommend if you're doing this sort of portal-first approach to communicate to those patients. So next slide, we'll talk about a case example. So Novant Health is a 2,300 provider organization in the Southeast. It's in Virginia, North Carolina, South Carolina, and Georgia. And over the past few years, they've rapidly ramped up the use of the patient portal from nobody in 2012 to more than 2/3 of their primary care patients using the portal in 2018. And they've done this using a 3-pronged approach. So the first part is creating a pre-login experience for patients, really creating value on the landing page with information that the patients want. So this is, if you're rolling it out, sort of during COVID-19, you've been rolling it out for a couple months, you're doing it now, maybe there's a spike in your area, letting patients know actually on that landing page what sites are open, what they should do if they're having symptoms, maybe allowing them to schedule a video visit even before they log in. Some do allow that. Find a provider. You can find a provider in that pre-login experience. Then they focused on creating a post-login experience for patients that allows the patient to schedule a video visit, to message with providers to follow up on visits, and to get their test results. And then they focused on aligning the patient portal usage with other organizational goals, like closing the care gaps and assistance with scheduling. They found their call center was overwhelmed with calls, and so really focusing on allowing patients to schedule their visits through the portal really worked well. And then closing the care gap included messages to the patient about missing tests. You're due for a pap test, you're due for a colonoscopy, things like that. Obviously, what of that is appropriate depends on what's available to do right now. But aligning those goals, the patient portal usage with those organizational goals, is really key for getting that internal buy-in. So the first two prongs are really focused on the value for the patient, making it worth it for the patient to put the effort in to get the portal and sign up for the portal. And then the last one is to get the whole organization on board so that everybody sees the portal as something that's contributing to the overall mission of the organization. Next slide. And so then case example 2, just walking through these steps. First is if your patients have email addresses and you're able to do it, bulk enrollment is a great place to start. You just pull the email addresses for any patients who haven't enrolled in the portal and upload them into the system. Again, if your portal has this option, and then send a series of emails to patients encouraging them to log in or pick their username or password, whatever is needed at that point. Some portals will allow you to assign usernames and temporary passwords to sort of automatically enroll them. So then the emails would really welcome the patient to the portal, show them how to access it. And so it'll be sort of that multi-pronged approach. Then the next part is to get the whole clinic involved. A recent study found that use of patient portals really soared when all office staff got involved. While patients place value in their doctor's instructions, they spend most of their visits interacting with other folks at the clinic, right? So if everybody on staff is on board with this, it's a real opportunity to promote the patient portal throughout all interactions with the patient. And then you want to promote, sort of same idea, promote the patient at promote the portal at every interaction. So if a patient calls in to schedule an appointment, have staff encourage accessing the portal and telehealth through the portal. There are several scripts available for this. When patients are checking out, if you are doing in-clinic, make sure staff say that they'll be able to follow up via telehealth from the portal if that's something that you're offering. And then even your providers can encourage that as well. And this is really something that has proven successful during COVID-19 for some clinics where, maybe the patient comes through for testing and has to give some information and is sort of automatically enrolled, or the staff who does that enrolls them in the portal, hands them the information about downloading the portal and letting them know that their test results can come through there. And may come through faster than a phone call sometimes if it's being pushed directly to the portal. And then again, using patient handouts or marketing collateral as an opportunity to promote the portal and thinking about those benefits of telehealth and saying that those are available through the portal. So again, thinking what we talked about earlier of what needs to be communicated and then the portal as the way to communicate it. You may add a QR code to any hard copy materials. So I saw Health Choice Network using a QR code at the beginning of this. So you can add a QR code to a sign in the window, to any hard copy materials that you're making available anywhere that links folks directly to the portal to download. And then, as we talked about in the beginning, making sure that you're marketing the benefits, not the features, right? So there are a number of benefits to patients, as we talked about at the beginning of this presentation. But it's not necessarily meaningful to patients if we say, there's secure messaging. What's more meaningful is to say, you can send a message to your doctor. and making it clear to patients that this is good for both of you. It's a good way to keep in touch without them having to, call in every time, for example. And then one other thing that's very important is promoting changes or new features. Some of your patients may have tried out the portal in, 2013 and had a very poor experience. And it's important to tell them, things have changed. These things are better now. All of our smartphones are better. Service is better wherever you go. And then this particular study noted that everybody says, the portal is really better for younger, more tech-savvy patients, but that actually with the right amount of sort of hand-holding and support, many patients are willing to engage. The study author says, while elderly patients may need a little more help navigating the portal, they're also your most motivated and engaged users once they're in. And then as was pointed out in the Novant case, you want to make sure to fill the portal with information customized to the patient's needs. And a little incentive never hurts. And this can be on the part of staff or the part of patients. So staff who promote the portal, there can be incentives there, or it could be incentives if patients choose to download it. It could be a monthly prize drawing or something like that. And then making sure to continue your efforts far after this initial launch, particularly if you want this to be your primary patient engagement approach going forward. Next slide. So then the other primary approach that we'll discuss is texting. So the opportunities for text messaging are your text messages get pushed immediately to the phone, which can be more accessible for low-tech patients. One advantage is that it really doesn't necessarily require a smartphone. We all have that uncle or spouse who's still using a flip phone. And even with the flip phone, those folks can still get informational text, letting them know that you're offering telehealth, letting them know your hours, or if you're doing drive-through COVID-19 testing, something like that. But they probably cannot receive a link to telehealth or conduct a video visit on one, which is a bit of a difference there. And so thinking back to the workflow we looked at in the beginning, the texting allows you to ask if they have a capability to do a video visit. And if not, then maybe flip it into an audio-only visit. And then beyond appointment and medication reminders and information about telehealth, it can also help educate and more easily gather pre-appointment data if the patient's able to do that. And then many EHRs are now integrated with text message-based functionality that easily pushes messages to patients. And it's important to know that your texting can increase your portal usage. So these can all sort of push in the same direction if that's something that you want to do. And the barriers are that depending on the method of text messaging that you use, it may require more steps to ensure HIPAA compliance. It doesn't provide as comprehensive of information, although it can be better. Obviously, if you have a nurse who's calling your patients, that nurse is better able to provide comprehensive information than texting. But if we're looking at this as a way to reach our patients who we haven't reached yet, or who haven't been calling in, for example, this is still a good option. It's not as easy to track access as patient portals. With patient portals, you generally are able to monitor usage, monitor responses, things like that. That may not be as easy with texting, although some of the texting tools that are out there are better equipped for that. And then message context can be lost more easily, just like people get in fights via text. Sometimes it's not clear what's meant by some text, or there's some additional context needed. And then not all your patients will have SMS-enabled phones. Next slide. And this is really about sort of texting as a valid approach to improve outcomes in general, as opposed to specific to telehealth. So I'm going to go ahead and go to the next slide. So this is not an endorsement of WellApp necessarily, just an example of some of the ways that texting can be used. I know somebody responded that they're using Care Message. I think I saw another example of someone in this group using Solution Reach. So any of those likely can be used in this way. And the example is sort of starting by configuring your appointment confirmation to encourage virtual visits when appropriate. So it might be Hello, patient. We look forward to seeing you. If you think you're symptomatic or have an elevated temperature, cough, sneezing, or other symptoms, consider our virtual urgent care. Click for more information. It could also say if you prefer to stay home, we're happy to see you via virtual visit. It doesn't even have to be, it has to be in accordance with whatever your strategic plan is for telehealth. And then if we're looking at a reschedule example, hello, patient. We look forward to seeing you. It's, again, same deal. If you have a elevated temperature, cough, sneezing, or other symptoms, we encourage you to reschedule your appointment until you've been fever-free for at least 24 hours. Text us back if you have questions. And then you can also, so that's for sort of your individual patient engagement, and there's a number of examples of what you can do on that front. And then you can also reach large groups of patients with campaigns. And so this sort of goes to that segmentation that I mentioned earlier. WellApp offers well campaigns to reach your full patient population. And so during coronavirus, this might be notifying patients on how to use telehealth with some of the information that we've already talked about, how to schedule a telehealth visit, asking them to avoid coming into clinic if they have symptoms, or directing them to the particular clinic that is doing COVID-19 testing, and if they're coming for something else, directing them to another clinic, for example. And the other option is reaching out to your high-risk patients, perhaps, who you haven't heard from, maybe those who are over age 60 or who have underlying conditions, to inform them of the resources available. Next slide. And so again, your sort of three-step process here is establishing an organizational policy around your text messaging effort and making sure all staff weigh in on the needs. There are many tools out there, and making sure that the tool selected actually meets your needs instead of sort of making additional work or additional complication is really important. HIPAA privacy and security rules don't need to be an obstacle to texting necessarily, but compliance really does require planning and diligence. And there is a piece on our website called the Health Center CIO's Guide to HIPAA Compliant Text Messaging, and you can find that on the HITEQ site. Then step 2 is sort of selecting your product, identifying an appropriate text messaging solution. Not all products are the same. You want to look for an EHR or patient portal integration opportunities. So somebody may have a great pitch for you, but if it doesn't work with your EHR or doesn't integrate well, that might not be the one. And you want to make sure to understand your service level agreements, privacy and security risks, and any costs that might be incurred by patients. That's really important. And then practice. Implement and actively practice managing the text messaging solution and how it will be experienced by the patient. Make sure that all staff are trained and educated on how the text messaging platform works and how to answer patient questions. So much like, and I should have said this when we were talking about the portal, it's really important that everybody sort of has the experience of using the portal to know what it looks like. Same deal with this, so one, you want to understand what the back end looks like for your own management purposes, but two, you also want to understand what it looks like for the patient. Next slide. And just organizational practices, best practices generally. You want to obtain written consent for participation in texting programs. You want to make sure that all devices that are receiving messages are secure and that the number for the patient is correct. You want to delete text messages after communication and make sure that any necessary information is documented appropriately. This is if you're managing the texting yourself. If you're using a texting platform, oftentimes you don't. That's done sort of within the context of the platform. And then your message content, your SMS text messages should not contain PHI, as you likely know. And again, if it's being done in sort of a one-off from an actual texting approach, you don't want to store the full names in the address book for sending text messages. And then if clients send messages that include PHI, don't respond to the original text. Instead, send a new message that asks the client to call you. And make sure you set up clear communications with clients and the public about two-way communication regarding whether you'll continue a dialogue, how quickly you're expected to reply, what type of information can be addressed via telehealth versus what they have, via text, via what versus what has to be done via a call or an actual visit. So having processes in place for that is really important. And just managing those expectations, making sure that patients know this isn't like texting a friend, they're not going to respond right away. You know, what is your time frame? Those types of things. Next slide. And so one key that's incredibly important to remember is to monitor your telehealth visits and patients to determine if you're serving your population. Studies have found that when transitioning to telehealth, clinics sometimes are suddenly serving younger and healthier populations, and this may be because those are the patients who are ready and able to use telehealth. So very important to monitor your utilization and make sure that you are serving your patient population, and again, using some of these approaches to reach out to those patients who might not have the telehealth skill right now, but could be assisted. Next slide. So leave no patient behind. This is no matter what approach you take, no matter how you're doing this, as telehealth gains traction and as it continues to be a way you're providing services, it's important to leave no patient behind. Telehealth will be a heavier lift for some patients than others. You may consider pre-visit technology support or perhaps a tech support visit before the actual visit. Those could be done by an MA or a CHW or somebody else from your team. They might also be done as part of the confirmation call that's done in advance. But really having a plan in place to make sure that the patient is good to go with the technology in advance and that has all the information that they need. And then planning ahead for any interpretation needs. This is really important for both patient and provider. Some of the workflows that I've seen for how providers are addressing interpretation needs are, I feel incredibly badly that that's how that's being handled. And there are some really good, or not perfect, but there are some good tools for addressing interpretation needs. Obviously, depending on the language, it can be trickier and sometimes the wait is longer, but really planning for those things in advance to every extent possible so that those patients who do have linguistic barriers are still getting getting care is really important. And then telehealth won't be appropriate for everyone. We just have to acknowledge that. Many patients won't have a smartphone or a computer or data plan or broadband internet or minutes on their phone, or a private place to do the visit, those types of things. And if those who can be served via telehealth are, then this can provide more safe opportunities for those who cannot be seen via telehealth to get the care that they need as well. Next slide. That's the end of my presentation. Any particular questions or thoughts that anybody wants to share? Any successes or challenges you've had in these types of approaches?
I'm going to go ahead and unmute the lines for everyone to participate on the phone if they'd like to, and also feel free to use the chat as well.
Too much, really too much.
Any questions that anybody has? Okay.
All right, Jillian, thank you so much. Really appreciate you taking the time. There's some really great, I know I've been taking notes for our team, but I think really some really great thoughts and considerations for us to consider as we continue to explore a more effective use of both using the portal and text messaging. So thank you so much for your time today.
Thank you.
All right, if there are no further questions for her, we are going to go ahead. I'd like to now welcome our newest addition to our HCN QTECH family, Healthcare Network of Southwest Florida. Dr. Courtney Witt is going to be joining us today to speak about their experience during this pandemic and how they have and are continuing to address care team burnout. So with that, Dr. Witt, I pass it over to you.
Good afternoon. Thank you so much for the spotlight and just for the opportunity to take a few moments to share some of the things that we've done just to kind of help ourselves and help our teams kind of get through some of the chaos and craziness that is our new normal. You can advance the slides, maybe the next two. One more. Okay, I lied. One more. Perfect. Thank you. I don't really think that I have to convince anyone here kind of that's in attendance of the need and why a response is required. I think we're all personally and intimately familiar with the impact that COVID can have, just each of us as various members of the healthcare workforce. I don't know that there's any of us that are immune from this. And just kind of some of the fear, the uncertainty, the chaos of it, really some of our most basic needs and sense of basic security challenged, and just by showing up to work every day. And with that, at the same time, there's kind of competition of resources, which can invoke and kind of bring about a lot of anxiety. And then just to kind of recognize that we're not just who we are at work. We might be parents or caregivers or members of a church or other kind of community organization, still trying to kind of keep afloat and manage the logistics of all of that and keep our head above water. We're all probably really familiar with this kind of the quote that this is the new normal, and kind of just waiting, is this going to have an expiration date? This kind of managing this chronic stressor. For those of you out there that are in Florida and kind of in the midst of preparation for hurricane season, it kind of feels like the calm before the storm at some point, you know. The question about like kind of while we're waiting for the peak, is this the peak? And like, oh no, that's definitely not the peak. Like, this is it. And are we in the first wave or the second wave? So the impact and kind of the that this may have is just immense. And taking all that into consideration is that COVID didn't hit us as a perfect world. We know that there's been a lot of information out there and a lot that we've probably seen in our own clinics and organization on burnout. And we hear a lot about physician or provider burnout, but really the whole healthcare team has an immense amount of responsibility and pressure that can be deeply personal and affect just everyday well-being and job performance as we're kind of balancing patient access with quality and kind of meeting some of the demands of our payers or the kind of electronic health records. It's just a lot that preceded this. And so how we respond can really impact how we get out on the other side of this, because there will be another side of this. So I just wanted to take a moment and kind of give a shout out. I think our CEO, Dr. Emily Potasek, who's a psychologist by training, just really sums this up really well and has helped conceptualize it through her work, actually working with individuals with trauma in the military and the VA. So healthcare workers in general, whether through self-selection or just some survival skills that we develop along the way, generally function incredibly well in a crisis. We have to. We don't have a choice in the work that we do and the impact that it has on the communities we serve. But at the core, we are humans and we have limitations. With repeated and continuous stress, we may all kind of break. Even those that generally have good coping skills, generally are pretty well, none of us are immune. We also know that resilience isn't something that you either got or you don't, and it doesn't happen by accident. We don't stumble into it. It's something that can be built and can be nurtured. Avoidance has purpose, it has value, it helps us kind of put a lid on some things so we can address what's kind of immediately before us. But over time, the more that we employ and engage it, the more that it will fail us over time and can create some difficulties of its own. And we also know that those who recover well seek support, engage the people around them, they ask for help early, and they engage in repeated self-care. Next slide, please. So kind of knowing this reality, as a healthcare organization, we knew that we had to find a way to respond to maintain our most valuable resources, which are the people that live our mission every day and show up to serve our patients and our communities. And so as part of that, we developed the idea of a For the Frontline conversation series. So in our model of care, so we have an integrated primary care practice where we have behavioral health and primary care providers work side by side, hand in hand for the shared assessment and treatment of our patient population. And so with that, our behavioral health providers are pretty uniquely qualified in that we are on the front line. So we've been here every day since the beginning of this whole pandemic with our nurses and our medical providers and our pharmacists. So we also, as part of our primary care behavioral health role, so we are here as providers providing the provision of direct patient care, but we're also consultants to the team and to the organization. So that's kind of within our normal kind of everyday task and responsibility and capabilities. So knowing that we needed to figure out something here helped us to shape this conversation series. You can go to the next slide, please. So just some of the logistics. So we created for 4 weeks a weekly online or virtual conversation series. We had 2 separate groups, one for all healthcare workforce and the other specific to providers. Just knowing that kind of some of the concerns of providers could be unique, but also by blending the group, it might not allow kind of other members of the workforce to kind of open up and speak as openly as they would otherwise. So we wanted to create 2 separate spaces, but ultimately everyone was able to self-identify which group they wanted to belong to. In terms of the format, we wanted to keep it informational, kind of providing some psychoeducation and trying to balance that with having an actual conversation and trying to use technology to facilitate that through chat boxes or just through audio conversation, and then using a lot of polls like kind of word clouds, emojis, multiple choice, open-ended questions, and really just trying to be prepared because it's really hard to assess what someone's level of engagement is or what their comfort is. So trying to plan for all scenarios, but also recognizing that people might have different needs, and sometimes people like something tangible that they can take home. In terms of the content, we tried to draw upon some comparisons in the literature, just what does the kind of injury and illness literature tell us? What is a natural disaster? What does kind of the war, kind of military literature tell us? What is the grief and bereavement models? How do they help inform and how do they kind of approach what people's emotional reactions are? And more importantly, what we can do to foster that resilience. We provided information and just discussed the adaptive nature of emotions and what they can reveal to us about our goals, our values, our beliefs. Why does this matter? Why is this affecting me in the way that it does? And how can I use that information to inform my needs? We looked at kind of doing an appraisal of the stressor as well as our own coping resources, building resiliency, and introduced the concept of post-traumatic growth, as well as discuss just the implications for identity and self-evaluation, like what might be coming up, like do I have to kind of behind the mask or the PPE put on a brave face when I'm really just like frightened, or maybe I'm angry that I'm in a position that I have to be here and show up, or that I have to pretend like I know, when a lot of us really don't know with the kind of the novel coronavirus what to expect or kind of what to do, or just kind of doing as best as we can and kind of figuring it out along the way. That can really bring up a lot for people. And then maybe from all that they have guilt, like because I feel angry and at least I have a job and things. So it can really bring up a lot of different emotions that kind of like shake people to the core. And then also, just as I mentioned, just some of the other social roles and kind of competing demands. And then kind of trying to create the space to process and kind of talk out loud about the course of a reaction, but then kind of closing it with, well, what can we do with it? So reviewing different types of coping strategies, so those that are kind of active or solution focused, or when there's things that we can't do at the end of the day that we don't have control of, how do I kind of manage that? What are some other strategies? How to get back to basics, focusing on our nutrition and what we consume in terms of alcohol or caffeine intake or water intake, looking at sleep, and then looking at physical activity. So that could be exercise, which is incredibly important for maintaining physical and mental health, but also maybe it's neutralizing a pretty activated system where we can't kind of, we're keyed up and can't really wind down because of stress, how to get our body to a kind of a baseline calm. The concept of self-compassion, I think probably all of us enter the field of healthcare because we have the capacity for compassion and care deeply about people and their well-being and their health, and having them live quality of lives. But it can be challenging to mirror that back to ourselves and treat ourselves with that same compassion. So really kind of discussing self-compassion and how to nurture that during this really stressful time. How to identify what our social support needs are and how to engage those around us to help meet those needs. And then, of course, spiritual coping as well. So that was just kind of a snapshot or overview of our series that we created. Next slide, please. If I can be completely honest, kind of expectation versus reality, I was pretty surprised that our participation rate was relatively low to what we expected through this forum. And then expectation versus reality, I think, for individuals as well. So we had individuals who signed up but did not attend. So had the expectation to, but the actual execution, it just didn't happen. So just some different considerations. I think one was timing. We tried to choose a couple of days of the week and a time of day. And going through a pandemic, there's probably not the kind of best time of day that could really meet the entire healthcare workforce's needs. So that might have been a barrier. And then we rolled this out during Mental Health Awareness Month in May. And I think just kind of the timing and the context of the pandemic, I think a lot of us have kind of like rode that wave, adjusted, kind of settled in, but we're still kind of experiencing that Groundhog Day and that kind of waiting for the kind of the calm before the storm kind of feeling. And so I think it might have been a time where people had settled, but also, as we know now, there's still a lot of concern out there. Another kind of consideration is the what and the how, just thinking about the conversation. You know, did some people know what to expect from that in terms of like, did they feel comfortable opening up and sharing and having this conversation with others, or did they really just want some of that tangible information? Obviously, because of COVID and our concern for exposure and to be able to bring this to the masses, it was important for us to do it online. But maybe for some, they really just needed that human connection, and so they weren't able to do that. And then for others, maybe there wasn't as much comfort with us providing it internally to employees. Maybe kind of having an outside facilitator might have led to a little bit more comfort. And then the who, in terms of self-identifying as essential, we had the full continuum of the healthcare workforce there. But maybe somebody didn't consider themselves as necessarily essential in that regard because they weren't kind of donned in PPE, doing nasal swabs. Maybe they were kind of doing data or kind of administrators, all incredibly important and essential during this time. We couldn't function without those rules, but maybe kind of not viewing themselves in the same way and feeling like it was open. And then again, the question is this truly anonymous? And so I think one of the most surprising things here for myself was that actually a lot of the participants, I think, were people like us, like administrators, kind of wanted to be there as flies on the wall to kind of get a pulse on what others were experiencing. I'm kind of curious in finding not only what they're experiencing, but thinking about how they could do more to support people. And so I think the biggest takeaway from this is just the need for us to ask our teams what their needs are, or if we've done some things, is this sufficient? Is this enough? Did we present this in the way that you needed to? Or did you really want kind of some more emotional support? Did you want information? Or did you really just kind of want some more kind of passive or like kind of just everyday things like extra, like permission to take a mental health day, or the ability to kind of cash in to have an extra source of money with some of the other stressors that might have affected your family, things like that. So if we don't know, if we don't ask, we don't know. And I found a lot of us wanting more information from people. So I think the biggest takeaway, again, is just for us to kind of ask and let people tell us what they need. Also, if others are considering how to engage the behavioral health providers in their practice or thinking about what they can do, I would also encourage you just to ask. They might have some insights into what some of the needs on the ground are, but also be able to help inform you of what they're capable of and what they can offer to the team and to the system. Next slide, please. So this is just outside of this more formal conversation series. These are just a few other things that we have provided to our organization and our team. Kind of that united frontline. Again, I think we hold so deeply that mental health and physical health are one and the same, and it could have been really convenient to use telehealth and kind of jump ship in some ways, kind of at the beginning of this, but it was important that we maintained our presence here on the front line to support our team and to support our patients, because we know that every other physical health concern didn't stop in the context of COVID, and the same is true for our mental health, and that's pre-existing, but also just managing the new onset stress of COVID and how it can affect any of us, as I mentioned. Another way that we utilize behavioral health is just to have them engaged in the daily huddles of the primary care clinics. And so it doesn't have to be a full-on group therapy, but just kind of taking a moment to kind of take a pulse and see where people are at. You know, maybe someone reveals that today is just really hard. I didn't sleep at all last night. And so then maybe someone else in the team can kind of have a little bit more compassion or understanding through the day, or kind of to chip in because they know that individual's then slack, or kind of just not fully in it and able to be fully present. Or maybe it's just setting, telling a joke, or kind of finding a little laugh, or setting a daily intention, like today I'm going to make sure I drink enough water, or today I am going to laugh instead of cry. Just those are some examples of how behavioral health can lead a discussion to really support and shape kind of the team. We've also worked to do some team exercises, so doing some yoga stretches and kind of finding some ways to make those a little bit digestible, some of those small but really meaningful things, doing some gratitude exercises or guided imagery. We've also been available just kind of that one-on-one curbside support or a consultative role. So maybe kind of noticing that someone on the team looked a little bit kind of down that day and just kind of checking in, or kind of letting people know that, hey, if you need to talk, it's not therapy, but you can kind of come to my office for a few moments and just kind of talk out loud or scream, or get a little bit of information on how people might manage stress, for instance. We've also worked to be available to our team by like kind of operations initiated. So if there's a specific employee that's having a hard time, you know, with their permission, so to connect them with the behavioral health provider. So like, I know that you're having a really hard time today. It would be okay if I talked to Dr. Witt and had her kind of just reach out to you to check in. And then also doing some team check-ins. I know through specifically implementing testing some of the first runs of that, or kind of having the first positive case can bring about a lot of anxiety, which can trickle through and kind of have a domino effect in a team, bringing in behavioral health to be able to kind of process that, but also give some recommendations or some supportive intervention. And then we also created some relaxation rooms. Just had to get the okay of our infection control team, but we found some cool rooms that we were able to dim the lights and put on some lavender diffusers and some white noise machines, maybe some adult coloring books or puzzles for people that just needed a few moments just to kind of take that break, kind of decompress, recharge their batteries. So that was just kind of another example. Next slide. And then lastly, just using kind of some of our internal, I guess, social media resources and kind of doing some posts. This is a great way just to share some important psychoeducation or other kind of tips and recommendations. And the great thing about it is that, number one, it's passive, so people can take it or leave it. People can share it, right? So if they're maybe okay, but they know that their coworker's having a particularly hard time, they can share it with them. It also gives us the opportunity to normalize it. So you'll see in one of these posts, like I'm kind of saying, I swear some days I've been going through all of these, whether it's like the fear zone, the learning zone, or growth zone. So to let people know that it's okay to not be okay. And then lastly, I think it's just symbolic, right? So if we're putting it out there, we're communicating that this matters, this is fair game, and kind of making sure that we create a culture that promotes mental health and well-being, that we kind of practice what we preach, for lack of a better word. And that's just about it as a quick kind of overview or snapshot about some of the things that we've done. I'm sure if we had time to plan it out and predict all this, we would have done a lot better. But really, this is just an exercise in trying to identify the needs and pull our resources together and do the best that we can do under the circumstances. So if anyone has any questions or comments or things that they've done in their practices, please share or reach out to me. Hello?
Dr. Witt, thank you so much. We really appreciate you walking through. It sounds like you all have had quite the journey and appreciate you taking the time. Hopefully we have you've got people thinking about how they can help support their care team members within their center. Any questions for Dr. Witt before we move on to the next section?
I'm currently unmuting lines in the case that anyone has any further questions to ask Dr. Witt. We do have a comment in the chat from Andrea Brooks, who said that this was definitely helpful. So thank you very much for sharing.
Thank you, and feel free to reach out to me. My email address is probably on the invite, but also in my slides.
Fantastic. So thank you so much, Stephanie. We'll pass it on to you to give the group an update on our latest resources.
Sure thing. Next slide, please. Awesome. Good afternoon, everyone. Thank you for joining us for today's QTECH meeting. I'm just going to go over a quick couple highlights of different resources that are out there and opportunities to participate in different things. So on the slide here, we have some key events that are upcoming for health centers. So one of which is the Today with McRae, the health center program updates that'll be taking place next Monday. There's also going to be other opportunities from the HITEQ Center. In particular, they're going to be hosting a webinar where they'll go over some shared care planning optimization using the EHR and how behavioral health teams and primary care teams can work together in the care planning process. We also just wanted to do a shout out for the quality work group. If folks are interested, that is upcoming as well. So just contact our team, the HCN Quality Programs team, to schedule an onboarding so we can get you onto the group as well. We also have some highlights here, one of which is NAC's Reimagining the Care webinar series. So just earlier today, I believe, they actually had a session as well where they were touching on some of the things that Dr. Witt shared with us today in terms of talent and workforce resilience and how to maintain those. And then the last one here is a nice shout out for NAC's telehealth office hour. So it's an opportunity for health centers as well as even health center control networks and other organizations to go on the line and ask some other sort of questions that they might have policy related or operationally for anything on telehealth. So we have information on how to access that there. Next slide, please. As you may have seen on the marketing slide deck that was shared prior to the start of our meeting, we are currently opening our optimization work group to now focus on telehealth specific objectives. So this is just a shout out for anyone that might be interested in joining the group as we focus specifically on telehealth over the next couple of months and how we can optimize that for both the patient and provider experience. So if you're interested, just feel free again to reach out to our HCN Quality Programs team and we can get you onboarded and ready prior to the next month's meeting. Next slide. Perfect. So as you may be aware, we have been hosting a COVID webinar series for the past couple of months. We just had one occur yesterday that was specifically focused on the new normal and how our health centers are shifting back to work and figuring out how to navigate the waters right now in terms of COVID and its impact to operations as well as with patients and staff as well. So we have a link here that's included on the slide so that you can click it and watch the previous recordings and access the previous recording materials as well. This slide just covers our COVID-19 resource library that we've been maintaining since the beginning of the crisis. We like to upload anything related to COVID that might be helpful or useful in these times to navigate. So it's a link to share for that. Next slide, please. This slide covers additional National Association of Community Health Center resources that are out there and available. Some of which that we've seen are very impactful are from the Health Center Resource Clearinghouse, where they've had an actual page dedicated to all things COVID as well. In addition, they have a Nodal Pod, which essentially is like a forum or message board for health centers to participate and ask questions during these times and learn from each other. So that's another great resource to share. Next slide. Perfect. And as you might have seen in our marketing slides earlier, we are also wanting to announce that upcoming soon will be our virtual educational conference opportunity, where both Alliance Chicago and Health Choice Network are going to come together to host this event for everyone. And the theme this year is Better Together, Innovating Now for Tomorrow. I believe that might be my last slide. Perfect. So thank you everyone for taking the time to join us for today's QTECH meeting. It was a pleasure having Dr. Witt from Healthcare Network of Southwest Florida share her story, her health center spotlight, as well as hearing from Jillian Massini and how we can integrate different opportunities for patient engagement to boost our telehealth services. So we're looking forward to seeing everybody next meeting, which is July 23rd, 2020. And as you see here, we have a shout out that we're actually expecting some guests from the U.S. Diabetes Institute that'll share a little bit more on their program and how they've been using patient engagement most recently. So thank you for joining, everyone. Have an amazing day.